Welcome to Taffy's 5th Annual Women in One Acts production of Wit by Margaret Edson. This is our talk back after the matinee on Saturday. We have two very special guest speakers, April Bupp, ovarian cancer survivor and advocate, and Julie Justice, nurse practitioner, will be talking about their own experiences. Yes. Talking about their own experiences with gynecological cancer and share information on awareness, types of treatments, support, etc. And Julie will also be speaking on some advanced care directives, which also end up coming up in the subject of the play. We're going to start today, though, with ovarian cancer survivor, April Bupp.
Imagine you're going about your day, minding your own business, when someone sneaks up behind you. You feel something pressed against the back of your head as someone whispers in your ear, shh, don't turn around, just listen. I'm holding a gun against the back of your head, and I'm going to keep it there. And I'm going to follow you around like this every day for the rest of your life. I'm going to press a bit harder every now and then just to remind you I'm here, but you need to try your best to ignore me, to move on with your life, and act like I'm not here. But don't you ever forget, I may just one day pull the trigger, or maybe I won't. Isn't this going to be a fun game? This is what it's like to be diagnosed with cancer. Any stage of cancer, any kind of cancer. Remission does not change the constant fear. It never truly goes away. It's always in the back of your mind. Hi, my name is April, and 11 years ago I heard the words, "You have cancer," but still I rise. I've endured 3 grueling rounds of inpatient chemotherapy, but still I rise. I've survived 5 major surgeries and 5 minor surgeries, including an emergency surgery to stop an internal bleed, but still I rise. I've taken 5 different types of medications to try to combat this disease, but still I rise. I've suffered the loss of many friends and family and loved ones to this dreaded illness, but still I rise. I've been through pain, I've suffered, and I've cried. This journey has been hard, I will not lie. But I will keep fighting, and I will not give up. And do you know why? Because still, like dust, I will rise. On February 8th, 2013, my life was forever changed by hearing the words, "You have cancer." Since my diagnosis of granulosa cell tumor of the ovary 11 years ago, I have been riding the waves. I've had ups and downs, good days and bad days, triumphs and disappointments, as well as fear, anger, and hope. But I am still here through it all because I have chosen to live and to fight. The type of ovarian cancer I have is very rare. It makes up about 1 to 2% of all ovarian cancers. So because of this, there is very little research and no proven treatment up here. So I have become my own expert and research scientist at times. I've had to become my own best advocate. I've had to fight and stand up for myself and my fellow GCT sisters. Because of this, I've been able to find the best care team to work with me through this illness. This disease has given me a platform to reach out, to help and support and educate others, and encourage them to listen to their bodies, make their voices heard, and be their own best advocate of their own health. To my fellow survivors, as someone told me at the beginning of this journey, welcome to the coolest club that you never want to be a member of. Yeah, cancer sucks. I'm not going to lie about it. It's true. It sucks. But there is no other way to, but you can get through this. First, you have to allow yourself to cry, to weep, to scream and be angry. You have to get in your feels. You have to let yourself grieve and be angry and sad and all of those emotions. And then, after you've given yourself time to wallow, stand up, brush yourself off, and put on your big girl panties and grab those boxing gloves because you've got to fight. And you're going to fight like hell. You can do this. Don't forget that you are not alone. Don't forget to ask for help, no matter how hard it is to ask. And don't forget to always give yourself grace and love. Now to the caregivers, loved ones, and supporters, if you have a loved one who has ever been diagnosed with cancer, remember this. They may never talk about it, or they may talk about it often. Listen to them. They aren't asking you to make it better. They just want you to sit with them in their fear, their sadness, their anger, just for the moment. Don't try to talk them out of how they're feeling. It doesn't help. It will only make them feel like what they are doing is being minimized. Don't remind them of all the good things they have in their life. Believe me, they know. They are grateful, but some days they are more aware of that gun and pressing in the back of their head, and they need to talk about it. Offer them an ear. Give them a hug. Be there for them even when they say they are okay, because they aren't. We aren't. And they need your love and support now more than ever.
Thank you so much for being here. I just want to take a moment. We are waiting for our nurse practitioner to hopefully be available. But I just also want to point out a couple of websites that we have available on our Taffy website and on our Facebook, and also in our lobby during our show for organizations that do either help fund research, do fundraising, also lifelines for cancer patients and their families, okrahope.org, ovarian.org, and then April also has her own personal fundraising page for the Johns Hopkins Kelly Gynecologic Oncology Service Below the Belt Stride and Thrive 5K and 1 mile walk.
Say that 10 times fast.
So please donate right directly to April's cause. Obviously, just such a great advocate for your surviving sisters. So thank you for being here. I'm now going to introduce
My nurse, by the way.
Yes. Well, then you would know better than I would. I will let you introduce if you don't mind.
I go to Johns Hopkins. That's where my primary care is. But because of my treatments I get them locally, so I don't have to go to Baltimore. So I go to the Hillman Cancer Center, and she is my nurse practitioner that I see, and I love her. She is wonderful, and you portrayed that nurse with such care and sweetness and tenderness. That's what brought me to tears, because the nurses I have seen in the hospital and getting my treatments, they brought me back to life. And she is an amazing person, and she always brings me back to life every time I talk to her. And I don't know what it is. Sometimes I'll just cry when I'm in there seeing her, and I'm like, I'm not even talking about anything. Remember the last time I was like, why am I crying? I don't know why I'm crying. But she's always there for a hug, and she's awesome. So
I just think it's because nurses are the best.
Right? Nurses have time to spend, but alhamdulillah, I am sorry for my in and out. I'm actually on call this weekend, so I have responsibilities to my job as well, so I apologize in advance. If the phone doesn't ring for the next 20 minutes, it'll be great. How many people in here actually have a personal experience with ovarian cancer, or just know somebody with cancer in general? Right, absolutely, right? I sometimes feel like I'm hard pressed to find someone who hasn't had an experience with cancer. So ovarian cancer is actually a collection of diseases. It's not just the ovaries, but it's also of the fallopian tubes and the primary peritoneal cancer, so the kind of the lining of the belly. And there's a bunch of different kinds, probably more than 20. And they're all treated a little differently and have different prognoses. So the information I'm going to give you today is really just kind of like in general and not really specific. But ovarian cancer is the 9th most common cancer in women. And this year, about 22,000 women will be diagnosed with some form of ovarian cancer, and 14,000 will die from that disease. 24% of cases are hereditary. So from a medical standpoint, if you're diagnosed with ovarian cancer, we actually recommend genetic testing because of the prevalence of that. That's one of the risk factors. BRCA1, BRCA2, or Lynch syndrome. So if you guys have any questions about that, let me know. Women who have been on estrogen replacement therapy without opposing progesterone. So we all know that, maybe don't, I know, that using estrogen increases your risk for breast cancer and gynecologic cancers if progesterone is not there to balance those effects. Women who have a history of endometriosis. As we age, the risk of ovarian cancer increases. Women who are obese or have a BMI greater than 30 also have an increased risk of ovarian cancer. If you've had a gynecological surgery, so a hysterectomy, you're at higher risk of developing ovarian cancer. That was a new one for me. I did not see this. And I get my information from the Society of Gynecology and Oncology. To reduce risk, thought we'd add some good things in here too. Taking birth control reduces your risk of ovarian cancer. And having children and breastfeeding also seem to reduce that risk. The problem with ovarian cancer is there's no really good screening tool, right? And a woman's anatomy is designed to have a baby. So an increasing ovary is not going to be very specific, if that makes any kind of sense. Things are really good to hide. Symptoms are vague, and they include abdominal pain and bloating, weight loss without intention, feeling full without having eaten very much, change in bladder and bowel habits, urinating more frequently, like just a generalized fullness in the pelvis, clothes not fitting right anymore, nausea, vomiting, fatigue, lower back pain, and pain with intercourse. Those should all be reported to your physician so that a workup could begin. Some of that workup could include blood work for cancer tumor markers, CAT scans, ultrasounds, whatever your symptoms are portraying, the docs are gonna take a look and see what's going on. And then we get to treatment options. And as I said at the beginning, treatment options vary, but typically some sort of surgery is involved. Sometimes we give systemic therapy or chemotherapy before surgery to decrease the size of the tumor in hopes to have an easier surgery. Sometimes we give it before and after. There's also different kinds of chemotherapy. So chemotherapy is tried and true, kill everything that grows fast in the body. There's also new medicines like immunotherapy. Those actually don't kill cancer. They rev up your immune system, right, and have your immune system attack the cancer. There are things called PARP inhibitors, which inhibit cancer's ability to repair itself and keep growing. There are monoclonal antibodies that do crazy stuff like make your cancer not be able to make new blood vessels so that it can't feed itself, so that the theory is the cancer will starve and die. There's also anti-estrogen therapies. Some ovarian cancers are fueled by estrogen, so we can turn a woman's body's estrogen off, because even after we remove the ovaries, you can still make estrogen from other tissues in your body, so we push you further into menopause. I know I'm missing a paper. So I was gonna say, there are other things that we can do. So there is chemotherapy that we can actually put into your pelvis, right, and swoosh it around and try to kill any cells that are just in there. Additional surgeries, you know, we worry about bowel obstructions, implants into the belly. So there's all kinds of things that we can do, but always finding it early is better. Clinical trials, there's a bunch of clinical trials out there, and what clinical trials do is take standard of care, the things that we know work against ovarian cancer, and it adds something else to see if we can get a better outcome. I became an oncology nurse about 20 years ago, and I'll tell you, if I would have became an oncology nurse in today's day, I don't know how I would have survived, because every day there's something new coming out. And eventually I feel that we're gonna be treating genetic mutations of cancer and not actually site of origin, right? There are multiple markers. We send ovarian cancer tumors off for what's called next generation sequencing, which finds receptors on top of the cancer cells to see if we have a medication that the FDA has approved to actually target it, right? So there are studies with that going on all over the world, trying to find a better way to cure ovarian cancer. How many people in here have heard of advanced care planning and have a document?
No, except for they heard about it, but definitely don't.
It's more than I thought, so that's great. I came in a little late, and as I was coming in, they were starting to talk about, you know, DNR status and CPR status, and I'm a nurse. I swear by The best gift that you can give your family is an advance directive, right? Because if you've ever had to make a decision for a family member that you don't know what they want, that is a horrible decision to have to make, right? So do yourself a favor. I'm going to talk a little bit more about what advanced care documents look like and what's in them. Talk to your family doctor. Get those filled out. There's no better time to do it when you have no reason to do it, because it is very, very hard to sit with someone who is actively dying and have that conversation, because it is not fair. Those decisions should have been made a long time ago. So things that advanced care planning does, and why people are scared, right? People are scared because if they say, I do not want to be resuscitated, they are afraid that their doctors will no longer take care of them. That is not the case, right? We will care for you until we can't care for you anymore, until there is no way that we're bringing you back to this world that is meaningful. You can set your own decisions. I had a young lady who once told me when we were doing advanced care planning that I couldn't let her see her family without lipstick, right? So that was in her advanced care document, so that when she died, we made sure she had her lipstick on before her family could come in. On another lady who said, you're gonna keep me alive long enough for my husband to come home because he was actively deployed. You can set these things with your families. Keep me alive long enough for this. Trial those antibiotics and see if they're gonna help me, right? But at the end, right, you decide how long and what can be done. And there's no greater gift to a daughter, to a husband, to your grandkids, that all they gotta do is follow what you want, right? Those are the most important things, to honor your wishes. Make sure that it is someone who will follow your wishes, right? You know, I'll share this because my husband thinks it's funny. He is not on my advance directive. Because he's either gonna kill me, or he's gonna let me live. I joke about this, but he also admits to that, right? That he doesn't think that he could let me go, right? If he had to, even if I said that's what I wanted, right? And then I joke about him wanting to kill me if it was a bad day, right? So my dad is, and my son, right? Because we all know that I'm not doing this. I'm the healthcare worker in the family. I'm the only one. Like, I am very clear about what I will allow to happen to me and what I will do. And if I can't make those decisions, I need to trust that someone will make them for me according to what I want and not the hard thing. But I also don't want my son, who is 30, to live with guilt or regret that he may have done the wrong thing. So think about getting those documents if you don't already have them. Change them as you get older, right? Because things change as we get older and how we experience things. The best gifts you can give. I'm good. Any questions?
Yes, yeah, for either of our speakers. If anybody has any questions.
So in Pennsylvania, though,
Yeah.
is the directive, or is it the individual that has the final say?
So, right, that's why I say you make sure that you do somebody. Like, because in Pennsylvania, you can get yourself a healthcare power of attorney. It has nothing to do with your finances. It is literally the person who takes care of your medical wishes, but they can overrule you, right? Unfortunately, that is the case. So that's why I say, make sure you trust the people that are on your advanced care directives and that you have these conversations with them often, right? This is a hard thing to talk about, right? Because it makes us kind of look at our own mortality, right? Nobody likes to do that because we're gonna live forever, right? That's life. You know, nobody thinks, but I could be driving home here and get hit by a car, right? You don't have to have ovarian cancer or a serious illness to need one of these documents, right? And again, it's really hard to do when you know that you're gonna die, it's even harder to have those conversations because you're living that, right? And that emotion of what's happening takes over, and it's hard to make those decisions.
Something else, and with that too, you know, yes, that's very important. Make sure that the people, like, make sure if you have those directives that people know that. From experience, my mother-in-law died in November, and she had called my husband and said, I'm having a problem breathing, I'm calling 911, and my husband got there, and she was in her bedroom on the floor, and they were like, do you want us to resuscitate? And he's like, she has a binder somewhere that has this in it, and of course her house was a mess. She never told anybody where her binder was, so they said go ahead and try to resuscitate. They weren't able to. She passed away, and then when we were at her house later that day, we were going through stuff, and I found the binder, and it said TNR. Well, it didn't matter in the long run because she did pass away, but we didn't know where the binder was. He's like, I think she has a binder. I'm pretty sure she has a binder, but he still wasn't 100% until I saw it and had my hands on it. So make sure, I mean, that situation was crappy, but make sure people know where it is and, you know, where to find it.
Because how mad are you going to be if they bring you back?
Oh my gosh, yeah.
Right? I mean, it's horrible to say. I had to have a conversation once with a cancer patient who was talking to the palliative care physicians about his code status, and he didn't like what they were saying, right? So I, the nurse, went in and said, do you want me to jump on your chest and break your ribs and bring you back to more of this? He was dying from his cancer. And he looked at me and said, no. Okay. That's all we needed. So sometimes, like, you have to be open and honest with your family, with your friends, with your people, like, to let them know what your wants and your needs are, right? This is, like, I can't stress it enough just how important having that document is.
I always say when I come back and haunt you with like, I'll be like,
Right.
You'll be like, you know, you'll feel somebody behind you, and it's me. Did that? Yeah. 100%.
Go ahead, any other questions?
I was just gonna say, I'm one of these people that has had the conversation,
Yeah.
because my sister-in-law's a doctor, and I'd rather have her and my brother, her husband, be my people that I trust to do that than my daughters. I think that's too much.
Correct.
I think that's too much for them. The one piece of advice, I have not followed through on it yet to do all these things, to fill out the paperwork, but we went through all the questions, and we actually did it on a, conference call with my daughters, so they could hear me saying to her what my wishes were. And one of the points that she made that I thought was interesting, though, was to keep a copy of those documents in the glove compartment of your car.
It's a good place
Because if you were in an accident, they'll
They're
look
there.
for that's where the police will go to look for information.
That's
So,
really That's good. Yeah.
Get them on file, you know, in the age of electronic medical records, like get them scanned into your charts, right? Take them into your doctor's office, say, I want this in there. I mean, there's a special place for that. There's a special place for that in there. So it's a great tool. And again, you can change them as situations changes. Just one recommendation, you have to have 2 witnesses typically when you fill out these papers. Don't have anybody that you name as your healthcare power of attorney sign it. Doesn't look great, right? Like that you have the person you're naming healthcare power of attorney witness your signature. There's always a question, did they make you sign it?
Oh yeah. Yeah, that's good.
Right?
So you said that you've been practicing for 20 years. Have you seen huge changes for the better?
From an ovarian cancer standpoint or a cancer in
Correct.
general?
Okay.
From an ovarian cancer standpoint, I feel like no, right? And that stinks. And the problem is that we're still not finding it early enough for the more aggressive types of ovarian cancer, right? The clear cells, the pap serous ones, the ones that we find at stage 3C, right? They're one step away from being metastatic and not curable, right? 80% of those cancers recur, typically within the first 2 years, sometimes in the first 3 months after we stop treatment. And that's the problem. There is no good screening tool. right? I feel like if we could find it earlier, right? Because everybody does better with less cancer, right? The chemo works better if there's only 1 million cells versus 5 trillion, right? Everything works better. So I'm hoping that maybe someday we will have like some kind of specific marker. I mean, I know we have blood work that can determine like a CA-125, which kind of lets us know for some women,
But
like,
not
not
people like me.
people like April.
My CA-125 is normal.
Normal,
I have ovarian
absolutely.
cancer.
So,
So,
correct, and that's the problem. And a CA-125 is also it's also a marker of inflammation. So if you have the flu, don't get your CA-125 because it's going to be falsely elevated, not from a cancer standpoint, but just because you had some inflammation going on. And I'm hoping that maybe someday in my lifetime we will find some way to screen. Ovarian cancer, if you compare it to breast cancer, the numbers just aren't there, unfortunately. Right? You know, 400,000 women will get diagnosed with breast cancer this year. Right?
Sure.
What did I say? Because now I forget what I even said. But it's only like 40,000.
Yeah.
Right? So, like trying to find, like even doing serial ultrasounds on somebody's ovaries, right, is gonna cost a heck of a lot of money.
Oh, yeah.
And it's probably gonna save 1 or 2 people.
Yeah.
Right? Not the numbers that we want. So we've got to find a way to diagnose it sooner and better. I think we have good treatments. I think the problem is that we need more treatments, and they're working on that. But I think the problem is when you start at 3C and not 1B
Right.
or 1A.
Right.
That's a problem in general.
Right.
that's one of my big things I talk to people about, is that I always say ovarian cancer is a silent killer, and like, okay, the women here, who has felt bloated? who has felt full? Who has had low back pain sometimes? Right? I mean, all the symptoms are things we feel every day, and so it's like, well, I feel fine. You know, I'm used to having these symptoms. So I always tell people it is worth the $25, $30 copay to just go see a doctor. The reason why I found mine, I had no pain, I had no issues. My periods were getting really far apart, and I was trying to get pregnant, and I wasn't able to get pregnant. So I was like, well, let's go see what's going on. And then that led to more tests, and then they found it. If I was a person who didn't want to have kids, they wouldn't have found this as early as they did. And my daughter, I tell her all the time, she saved my life because I wanted her so bad that I was trying to have a baby and I couldn't, and I didn't know why, and I found out why, and by the grace of God, I was able to have her after I went through chemo and everything. So,
Are you finding that people are getting cancer younger and younger? I'm 30,
100%.
and I have multiple friends. I have a friend who is an ovarian cancer survivor. She was diagnosed at 26 with ovarian cancer, and my mom's like, I didn't have friends when I was in my 20s with cancer, and I'm like, I'm 30, and I have probably 20 friends that have all faced and dealt with cancer.
Yeah. In general, I think like if you look at all cancers, just because of the numbers, we're seeing more and more breast cancers in 30-year-olds, right? That aren't genetically related. It used to be like if you had a family history and a BRCA mutation, like those were the women you were seeing in their 30s and early 40s getting breast cancer. But no, now it's just you're just getting it. They just updated the colon cancer screening guidelines that it now starts at age 45 instead of age 50 because people are dying.
I was 33 when I was diagnosed.
Right.
And,
So
I have adult granulosa cell tumor. There is juvenile granulosa cell tumor. And I know people who were diagnosed at like 17, 18. I know a girl who had juvenile GCT, and she was 20-something. She died.
Yeah.
She fought so hard, and hers was juvenile tends to be more aggressive.
So, screening tools suck.
Yep.
If you wait for symptoms, it's kind of
Yep.
too little, too late. I know like we do pap smears, but that's more like cervical cancer.
Yep.
When they do an internal and they like push down on your over, like can they feel it? Like is there a clinical way that
So
they
it depends, right? There's anatomy, right? Because if you are obese, it is really hard to feel an ovary. right?
They're
Because
teeny,
there's
they're
a
so
lot,
little.
I mean, they're tiny, and even something that, even if you had an ovarian cyst, right, that is 3 or 4 centimeters, so 2 inches, it's still hard to feel because there's so many other things. I mean, I do internals on every woman that I come across, and some things I can feel, sometimes I can feel a normal ovary depending on someone's anatomy, and sometimes I can't. And I always feel like if I can't feel something, that's good, right? Because if I can't feel something, doesn't mean something's not there, but it's definitely not obvious. But everybody is built a little different. So it's really hard. But that's the intent of when we're doing that.
Have they been doing any studies in the United States? I read an article about in Scandinavia, I can't remember which country though, they had a lot of women in that study that allowed their information, their spending information to be put into a program, and they found out that the women who had more purchases of sort of like, things you would do to treat a tummy ache or that sort of thing, wound up having, and I can't remember whether it was ovarian or uterine, but one of gynecological cancer, and they were looking at as that's a possible tool to say maybe this person should get screened.
Not that I am aware of, but now you have piqued my interest.
It sounds similar to how you avoid certain products with grocery stores, like certain deodorants,
Oh,
because
absolutely.
they lead to breast
Correct.
cancer and everything.
Correct.
So that would be an interesting
Yeah.
way to do it.
I don't know. I read that. I read it within the last.
I'm gonna go home and I'm
I'm
gonna do some work.
We have time for one
Yep.
more question. Go ahead.
Please correct me if I'm wrong, I'm just curious, if, from what I've learned about cancer, it's like a cell mutation,
So it is, right? So cancer is just a cell in your body in a certain location, right? That when it makes a copy of itself, something goes wrong, right? And then it makes a population of cells, right, that have one mutation, right?
but then how does that get passed down?
So that does not. You have to be born with a mutation. So one of the most famous or infamous mutations is BRCA, right? So you are born with a BRCA mutation. You get half your genes from mom, half your genes from dad, right? One of them is already broken, right? So as you go along, this one is keeping cancer in check, right? But it eventually will wear out, and it doesn't have the replacement to keep going, right? And that's where the genetic mutation comes from, right, that you're born with. So there are germline mutations, which is something you can get from your mom or your dad and pass on. And then there are what's called somatic mutations, and those are mutations that are made to become cancer, that cannot be passed on to your offspring. Does that make sense? And we check for both, because we want to know. Because you can have a BRCA mutation in your tumor, but not a BRCA mutation that you were born with.
And they're finding all kinds of mutations.
Absolutely.
That they don't yet have treatment for, because
Right.
I have the FOXL2 mutation, which is very typical for my type of cancer, but there's no
We don't have
treatment for
medicine.
FOXL2 yet. But
Not yet.
knowing that I have it is good, because down the road, if they find something for it, they'll be like, hey, I have that, I think let's try it, I mean, with what I have, the reason why I've been on so many medications and so many treatments is there's not one treatment that has worked for every woman with the type of cancer I have. And so unfortunately, I've tried a lot and a lot hasn't worked, but I've been on a medication for a little while, and I just shared with her in January I had a CT, and it said no evidence of recurrent or metastatic disease, and I am well. So hopefully they'll continue to work. So
That is a lovely thing to end on.
Congratulations.
I feel like we could be here for much longer, learning so much more. Thank you so much for being here, for answering our questions, for giving us some information, for giving those that will end up watching at home information. I just want to reinstate again, thank you all for being here, for your questions. April, thank you for sharing your story, a bit of hope. I can't state enough how much we appreciate that. There are websites on the TAFI website and on the TAFI Facebook page. I named a few. I also don't want to forget it is a local facility. HopeLifeline.org. They support families and cancer patients of any type right here in York County. They are internationally recognized and are also operating and help cancer patients in 27 different states. So
There is also the Teal Blanket Fund at UPMC Hillman Cancer Center.
Oh,
It is
fantastic.
it is also local through the foundation of UPMC. Yeah.
Oh,
I just thought about
Can
it.
you find that online?
Absolutely.
All right, so say that one more time for
The Teal
everybody.
Blanket Fund.
The Teal Blanket Fund, thank you. We want to try and highlight as many organizations that are helping out with cancer as possible. Again, that's also okrahope.org and ovarian.org, and you can also find April's fundraiser for the Johns Hopkins.
If you like to run or walk 5Ks and you want to be part of my team, you can come with me and we can all have April's Army. That's what I call my people, it's April's Army.
To April's Army.
We welcome all members into my army, so.
There's a red walk